Yeah.
Can you hear me? Testing, 1, 2, 3.
Yeah, talk with the voice you'll have. So, I'm gonna, like, with the voice you'd normally have, like,
Okay.
you know,
Um,
because you're usually. And welcome, hello everyone, and welcome to PerfWeb number 73, 72. Okay, great. We're going to be, of course, giving the lecture today on ECMO, who, how, and for how long. Before we get started, let's go straight to the opening remarks. The program is, of course, sponsored by HET, us, and we're hiring, though. Join us, okay? We interviewed a couple of people. We interviewed another person yesterday. Outstanding candidate, very happy, coming out of a great program. You know, our two new grads that we hired, I guess technically last year, have passed their boards, and great opportunity for us to continue to expand our practice. And so we're continuing to expand, continuing to hire. So please reach out to us. There's the website, het.us. Social media, make sure you like, follow, share, subscribe, give us the thumbs up, click the bell icon for notifications on all the social media platforms, including YouTube, and make comments. Comments drive people to the site. That's what YouTube, I guess, looks for. So make sure you do that for us, okay? Check our websites out, perfusioneducation.com, which is our library where you can join. It's a member site, but membership is free. You only pay if you need CEUs, and also, of course, perfweb.us to see what upcoming programs we have for coming up for 2022. We'll be populating that very soon. And I don't know if you know this or not. You can't. So I'll introduce you to our special guest today here momentarily, but I'm going to ask my special guest. You can hear her. You know, I'm going to do the New Orleans conference first week of June, 2022.
Yes.
You're coming, right?
I'll be there.
Okay, I knew it. But we are, so be looking for that, okay? Mark your calendars. June, the first week of June, Thursday, Friday, Saturday. You want to contact us, reach out to us. There it is, contact at perfusioneducation.com. Our call-in number, we're going to leave the phone lines open, so if you want to call in, just go ahead and call in today. Would love to hear from people. And of course, check out our MediWeb app. How's our MediWeb apps coming? When are we doing the update? They're waiting for me to do the update. Okay, we're going to be updating it, but it's a great app as is. You have the app.
I do have the app.
And it's a good app, isn't it?
Yes, I do.
Oh, good.
Very
We need to,
handy.
you know what? I can't, but as soon as we introduce you, you're going to tell everybody about that app.
No.
Because I need to sell 1 million of them, okay? 1 million, that's all I need.
Okay.
1 million apps, and I'm gone. Podcasts, you can listen to us on your favorite podcast streaming service. Just look it up, Perf Web Podcast Series, and listen to all of our programs. Okay, let's go straight to introductions, please, of our honored guest, Sharon Kroslowitz, who has been a perfusionist for now 30 years and has been working with us at HET since 2014, though I knew you sooner than that. Came down and talked with you back when you were the days when you were at Memorial Hermann, if you remember that. Those days, you remember that meeting we had?
Yes.
You and Debbie, and it was a lot of fun. You received your perfusion degree from Albert Einstein College in the Bronx, New York, so you're a Bronx bomber. You immediately after post-graduation, you began your perfusion career at Columbia Presbyterian Hospital in New York, and you specialized in pediatrics at that time. Over the course of nearly 30 years, Sharon has worked in various institutes in New York, Florida, Texas, including in Columbia Press, and Valhalla, is that how you say it?
Valhalla.
Valhalla Medical Center. And Arnold Palmer Children's Center, Memorial Hermann TMC. You're experienced in adult, pediatric, neonatal, transplants, LVADs, ECMO, hyperthermic perfusion, chemotherapy, autotransfusions. I'm assuming by the hyperthermic you mean the high-pack procedures? Yeah. Have you ever done systemic hyperthermia?
No.
Yeah, that's very interesting. People don't like it. I can tell you that right now. I've tried that a few times. And we tried it back in the 80s, back with AIDS, and then tried it again here fairly recently. It's really, there's a point where the temperature it goes up just too high, and and if you don't go to that level, I don't know what the right answer is, whether it's a combination. It's really hard to say, but I do wish those researchers well. But it's tough. It's very, very tough to manage those patients. But since you've joined HET, you have come here a couple of times and done great on the program. You've bailed us out. Tammy's doing a case, and you came in her place. I did have to beg just a little bit, but you did come, which I appreciate so much. And your hobbies include your 2 laboratory retrievers, spending time with your 3 children, 3 sons, who are in various stages of college at this point. And you like to cook, cycle, garden, and do stained glass. We're looking for a new set. Maybe you could help us out with some stained glass.
Okay, sure.
We may like that very much.
Okay.
So tell us about the app before we get started.
Oh, it's got a lot of great features on it, you know, for looking for calculations, how long it's going to take for an E-cylinder to become empty at certain liters.
Isn't that cool? Isn't that a cool
yes, I mean, there's
thing to have?
things, you know, I mean, it's great just to pull it up because you can easily access a lot of different formulas that you go, oh, what's that formula again, you know, so
Yeah.
it is a great app.
It is. Thank you. I appreciate that. Magic, we need to turn that into an advertisement, the app ad. Okay? And it was organic, which is even better. Okay, so the plan today is I'm going to give the lecture, and of course, you know, this is supposed to be a 2-hour session, and no one wants to listen to me drone on about slide after slide for 2 hours, but I do have a lot of slides. What we're planning on doing, or the plan is to do several slides regarding one section or the other as we progress. And then once we get to a change from either the who or the how long, we kind of discuss that back and forth. So we'll leave the phone lines open, and as we're doing this, if you want to contribute, either, of course, via the telephone, which would be great, or you could do it on the chat or whatever it may be, whether it be the Facebook and the Twitter, or you want to do YouTube. I monitor YouTube. Those guys in the back are looking at Facebook and Twitter. Okay, so let's go ahead and get started with our slides. And before I get started, so since you're here, in a word, what's your view on who should get ECMO?
Everyone that needs it.
Anyone that needs it?
Yes.
Okay.
I'm sorry, but I'm an advocate for if you need it, and we have the equipment and the manpower. Yes, we should give it to you.
So I'm going to see if I can change that
You won't.
opinion.
You know, you and I are going to.
Let me try. Let me try. Give me an opportunity to try. Okay. So, you know, although everyone listening to this is already going to know what ECMO is, I'm just going to go through this definition, and you can find a definition for this anywhere you go. This happened to come out of the American Thoracic Society. Extracorporeal membrane oxygenation, or ECMO, which is the acronym, is a life support machine. People who need ECMO have a severe and life-threatening illness that stops their heart and or lungs from working properly. For example, ECMO is used during life-threatening conditions such as severe lung damage from infection. That could be from COVID, that could be from pneumonia, bacterial pneumonia, viral pneumonia. It could be from a whole variety of different things, aspiration, you name it. Or shock after a massive heart attack. So that's basically what is ECMO. So there's our foundation, right? So who gets ECMO? Now, in Sharon's thought, anyone that needs it. But trying to be a little more scientific about that, because there's some people who need ECMO, but they're not going to get ECMO
Maybe
for
they're too old,
a variety
or
of
maybe,
reasons.
you know, there's other issues going on.
Yeah, but you know, I got a telephone call from somebody who I know, and a very nice person, and he was telling me about his mom was in the hospital, at one of our hospitals, and you know, she had you know, pneumonia, and she really needed ECMO, and I was like, well, you know, how old is your mom? And when he told me 87,
Oh, yeah, see.
but she was to him, she was a young 87, and we're seeing those pressures coming from society. And this is somebody who probably really knows very well it's an unrealistic idea for that patient. But again, he was explaining to me how active she was, etc. And it is his mother. So it gets very, there's a lot of emotion when it comes to making sometimes these very important and difficult and challenging medical decisions, I believe. But who gets ECMO? Well, there are diagnoses, right? There are inclusion criteria, there are exclusion criteria. But we're not going to get too deep in the weeds with this. We're just going to talk about some of the more common diagnoses that you would select or choose or offer ECMO as an option. So for circulatory collapse, it would be a big MI, big myocardial infarction, big heart attack. Could be pulmonary embolus, could be post-cardiotomy syndrome. You can't get the patient weaned from cardiopulmonary bypass either after coronary bypass surgery or valve replacement or both. As a bridge to a VAD or to a transplant for a patient, let's say, that has a viral cardiomyopathy or an idiopathic cardiomyopathy, and they just have a failing heart, and they're young, and they need a transplant, but they can't find the right heart for them. Then it's a good idea to put that patient on ECMO if you need to bridge them until you could get a more permanent VAD or wait for the heart to be available. And I went ahead and put Takotsubo because I think it's such an interesting phenomenon. I'm reading more and more about it these days, which is broken heart syndrome. And it's very real. In fact, I've seen a patient, if you remember, at North Cyprus. I don't know if you ever helped us with that particular case.
I did. I'm trying to remember which patient, but I vaguely remember.
Yeah, so I can tell you the story about her, but let's first describe Takotsubo. So a taco, it's T-A-K-O, so I guess it's taco, and subo. So a taco is the octopus, and a subo is a trap. So a Takotsubo is an octopus trap. And if you look up at the top left picture, which is on the top right of the screen, that is a ventriculogram of a left ventricle that is experiencing Takotsubo. And you can see the apex of the heart, of course, down by the right. It's the little arrows pointing to it in a line. And then the base of the heart where you have your aortic valve. You can actually see the aortic valve. So that's more or less the LV outflow tract is really kind of what you're looking at there. And to the right is an actual Takotsubo, which is the octopus trap. And you can see the similarity in it. It's so amazing. And in the bottom picture, what you see is a fishing boat with these traps tied to them, these Takotsubos, tied to them going to the bottom. An octopus or octopi like small, dark places. So they will go in there as a hiding place, and of course they have them marked with the flag and the buoy, and they come pick up all of their traps, and inside they find their octopus, and there's their crop or their meal or whatever it may be. So that's how Takotsubo got its name, is actually from this. I thought that was just somewhat interesting. But the lady that I was talking about, the sister worked at the hospital at North Cyprus as a case manager. And her sister's husband ended up in the emergency department, and he had had a massive MI. All resuscitative efforts failed. And they went out and told the wife that he had died. And she clenched her chest. She started breathing rapidly. She looked at the intensivist, who her sister knew, but she kind of knew him from various different social functions, and said, "Please don't let my children lose both parents on the same day." And she went out down on the floor. She was arrested. They did CPR, took her to the cath lab, and found this very phenomenon. The ventricle, they got a pulse, a heartbeat back, and her left ventricle was just ballooning out paradoxically to contraction. And she had what was then referred to as classic Takotsubo. And we put her on ECMO, and she was on ECMO for about 48 to 55, 56 hours. Was weaned off and went on to do just fine and still is alive, living a perfectly normal life. So it was just a temporary stunning with no permanent effect later on. So I thought that was very interesting.
That is interesting.
But I mean, we've experienced it. I've been heartbroken before, and you can have you ever experienced that where you can actually feel like your heart hurts?
I can't say hurts, but just maybe a heaviness
To it. Yeah. I do. I think hormonal effect is really, really huge.
Sure.
So anyway, you can also use ECMO for pulmonary failure, of course, ARDS. We've seen a tremendous amount of ARDS with COVID, but it's also, you have influenza-related ARDS. ARDS is just acute respiratory distress syndrome. So it can be from a lot of different causes, but there are certain things we look for. Consolidations, of course, you lose your PF ratio. Your lungs aren't working in a very global way as opposed to just regional. It's ARDS is both lungs, all of the lung that's going to be affected. Of course, you could just have hypercapnic respiratory failure. Not uncommon to see that. You could have aspiration. We talked about aspiration pneumonia. And, of course, bridge to transplant. You could have idiopathic pulmonary fibrosis. Although we are seeing a lot of pulmonary fibrosis post-COVID, it's not idiopathic. It is COVID-related. But, nevertheless, you can, that disease does also exist, and it's a purpose for ECMO or a good diagnosis for ECMO as you're waiting for transplant. Pulmonary hypertension, you could have obliterative bronchiolitis. There's a lot of, or bronchiolitis obliterans, however you want to choose to say it, same thing. And I think we're also seeing a lot of that, which is resulting in pulmonary hypertension from the COVID destroying the airways. It's really an interesting phenomenon, what we've been seeing and how it's played out. So ECMO, I think we have now seen in just a few slides, is a bridge. It is a bridge to something. It is like the Golden Gate Bridge, which goes from San Francisco, which is on the far side of this picture, over to Sausalito, which is on the foreground side of this picture. So you're looking towards the bridge, crossing the bay, the San Francisco Bay, going from Sausalito over to San Francisco. Or you can be like this bridge from Glasgow, Scotland, which is the classic bridge to nowhere. And that is the part about ECMO that can be very difficult, is evaluating and assessing which patient is going to be the a good candidate for recovery, and if not recovery, before we get this started, what is our exit strategy? Should you have an exit strategy before you get started? And these are some very important questions. Let's go and just open it up for Sharon and I to discuss this, because I want to get her thoughts, and then we'll come back to the how do we do this. So there's sort of my tossing the ball over to your court, is you have patient X. Patient X needs ECMO. We're just going to say, for the sake of this discussion, it's pure pulmonary failure. It's going to be VV ECMO. You have to ask yourself a whole lot of questions about this patient. And one of those questions has to be, I believe, what is the exit strategy for this patient? What say you?
I mean, I am a strong believer in everyone needs a chance. And especially right now in this time when we're still learning from COVID, you don't know. We're so uncertain still of what our outcomes are going to be.
Mm-hmm.
And we've had some great successes, right? And that makes it all worth it. I don't think you can come into this and say, okay, we're going to put you on ECMO for 2 weeks or 3 weeks, and then if you're not improving, we're turning you off, because you and I both know it's taken a lot longer than that for a lot of our patients. And everyone deserves that chance.
Mm-hmm. Everyone deserves that chance.
Well,
I agree with you that everyone deserves that chance.
As long as you don't have contraindications, say like advanced age or.
Well, yeah.
Right?
Yes, yeah, but I'm setting this up like I'm like an attorney right now at trial, and I'm trying to get you to go. What I know the path you're going to go, so I'm trying to get you to go down there and commit. I need you to commit. Everyone deserves a chance.
They do.
Notwithstanding these exclusion criteria, like the patient is decapitated. Well, we're not doing ECMO on a decapitated patient. Okay, patient's 93 years old. We're not doing ECMO on a 93-year-old. I understand that. Patient, even though, let's say the patient has a BMI of 79, there are people that have put patients with a BMI of 79 on, and they survive.
We've had a few close
so
to that
maybe
ourselves,
that
right?
isn't 100% either, right? So they have a terminal illness. They have cancer that's untreatable. It's terminal. Let's say they're in hospice. We're not going to put that patient on ECMO, or shouldn't. I don't believe.
That's true. And I know we've gotten to the point on many of our ECMO runs where it's, what, 70 days, and you're like, oh my God, we're going nowhere. And then all of a sudden things turn around. Doesn't that make it all worth it? All the effort is worth it then.
It is.
Because if
And
it were
I see that passion in you. I do. And I appreciate it and respect it tremendously.
I mean, I want to fight for these people. And especially because now it's so different with the COVID patients because they're awake. They're talking to us. We're getting to know them, what they did before they came into the hospital, what their hobbies are, their families, who their kids are, how many kids, their ages. And you become attached to these people. And that makes me want to fight for them even more. And, you know, we've lost a lot of people in this last couple years with COVID.
We have.
And it sucks.
And we've saved some that I never thought were salvageable, and we've lost the ones that I absolutely thought were salvageable. Yeah. And none of it makes any sense to me. I can't quite figure it out.
But isn't it worth giving them every shot you can so that maybe they can have another, who knows, 6 months with their family, you know, a year? Heck, even if it's a week. I'd want another week with my family. Right? Wouldn't you?
Yes. I mean, I view it a little differently. I mean, if we're going to get into a philosophical conversation about this, if I know that that is the end, then although I would want the time with them, and they probably would want the time with me, it just, from my perspective, delays the pain that they're going to have to go through, the loss or whatever. Hopefully, I hope.
No, I think that I disagree, because if you're taken from them abruptly or before they're ready, and they feel they didn't get a chance to say goodbye to you, say you're on ECMO and you don't wake up, we don't wake you up, you're not one of the awake patients.
I'm not going on ECMO, okay? Let's just make sure.
That's what you think.
I'm not going on ECMO, but go ahead.
We're going to put you on an experiment on you.
One of my sayings, yeah, no doubt. One of my sayings, of course, which I've said to several people in my life, there are fates far worse than death. Yes. But go ahead, you were saying.
I've lost my track now. But.
You lost your well, you were talking about the time with your family, and they're not ready to say goodbye, and et cetera.
And I think that's important. I mean, I think if you can give somebody, however much more time with their family, they have a chance to come to closure with the family member, the patient, and I think that's better than saying we put you on ECMO and you didn't wake up and they never got a chance to say goodbye or say I love you or whatever. I mean, I think COVID has made us see these things. We've gotten more involved with the families, more involved with the patients. I mean, I get very close to my patients and their families.
And a lot of that is just simply because of
the length of time.
Duration.
Yes, exactly.
Right.
Yes.
The duration of time that we're managing these patients.
Yes.
That we see them every day for weeks and months.
It's so cool because they're awake and they're talking and they're eating, and some of them are walking down the hallway and exercising. It's a whole new ball game, but it's really been an eye opener.
It has been, absolutely. It's really what I think it's taught me is how durable the human body actually is. How much insult the human body can actually take.
Oh, yes.
And still, it's that fine line. It can tolerate so much, but if you give it one more straw, it just drops right off the cliff. It's very amazing the way that happens. Okay, so let's go back to those slides. So how do we do ECMO? What do we do? Well, this is something that John Ingram had discussed once before, but I want to go over it again. So basically there are two types of ECMO. You have veno-arterial, used to treat circulatory collapse, and you have veno-venous, which is used to treat isolated pulmonary failure. So where you see the dash, so when you look at V-A, or you look at V-V, where that dash is located is where the oxygenator is. So in V-A, it's the venous access into the oxygenator returning to the arterial circulation. In veno-venous, it's venous access, going through an oxygenator, going back into the venous circulation someplace else to achieve what you're trying to achieve. So it's very important when you are describing your ECMO cannulation strategy and when you're writing it down that you not just simply put, especially if it's a hybrid, which I'll show you some examples of, VVA. If you put VVA or you put VVV, no one knows if you have one access and two returns. No one knows if you have two accesses and one return. You don't know if it's VAV, if you're veno-arterial venous, or if there's some other configuration that you're doing. So it's very important that we use. Now, I was going to use a different picture to describe or to show exotic, but I thought better of it since this is a family show on YouTube. But there were some other options that I had. I considered it, okay? And you can talk to Tammy about that. She will tell you. In fact, she's the one who said, I don't think I would do that if I were you. I think you better go with the car. I'll show it. Yes, I'll show you. So it's really not that bad. It was a New Orleans picture.
Oh boy.
Okay, so it's not that bad. Okay, it's still New Orleans. It was on the webs, the interwebs. So in this situation, here are some complex and exotic ECMO cannulations for VA and VV ECMO, again, depending on what you're trying to accomplish. So in this configuration, you have venous access, oxygenator, venous return, and arterial return. So what I would suspect here is that really you're trying to support the circulation with the VA, or you're trying to support the right heart, and you need the pulmonary support because your lungs are not providing gas exchange. So that's what I would assume just from this. Probably more a pulmonary problem because they put the V first, and then the arterial circulation is more for, let's say, right heart support. So this is going to be most of your flow. This is going to be a reduced flow just to give you some RV unloading. That's what I would expect here. With VAV, I would say you have complete heart failure. You have venous access, oxygenator, going into the arterial circulation, femoral cannulation, in which case you need to have the venous to avoid Harlequin or north-south syndrome or differential hypoxemia or whatever you want to call it.
Right.
Then you can have VV, two venous accesses into an oxygenator back to venous. Or you can have one venous access going to two venous returns. You can have two venous accesses going to two venous returns. You can have three venous access going to one arterial return. These are some examples of these are cases that actually were done. These cannulations actually do exist and have been done. Then you can have parallel circuits. You can have the butterfly, which Matt and Vanderbilt from Vanderbilt during the faculty forum I think 2 weeks ago discussed, which is venous, and a second circuit venous to venous with the two oxygenators.
What was the reason for that?
They needed that much flow.
Big
because
patient?
the patient, not necessarily, super hyperdynamic.
Oh, okay.
When your cardiac output, and we've discussed this in previous programs, when your cardiac output's 14 liters and you can only flow 5, you cannot oxygenate. You have too much blow-by. And so, especially if your lungs are just not working at all. So it could be a younger patient, super hyperdynamic. So if you can increase that treatment to 10 liters or 12 liters, you're going to have a much better PO2 arterially, and so you would use these parallel circuits. And I have pictures of these, so at least you can see that. Then you can have veno-arterial plus veno-arterial parallel circuits. You can have venous to venous plus venous to arterial as well. So you can have complex cannulation as a single circuit, and you can have complex and exotic cannulation or systems with a parallel circuit. Now, this is not a tandem circuit. When I say parallel, totally different than having oxygenators in series for better gas exchange.
Right,
that does
right.
not improve flow whatsoever.
Mm-hmm.
So here are some images of it, and if you look here to the top right, you can see the butterfly technique. So you're draining from the bilaterally on the venous femoral veins going into the IVC, probably at different lengths, different heights or depths, as you wish to call it, going through the oxygenator, going back up into, yes.
We lost the screen mirror.
Oh, you lost screen mirroring? Okay, sorry. 1 second, guys. Sorry about that. Would what the quality of that bonus week, many cultures that bonus week burdens the healthcare system? I'm not sure I understand that. What would the quality of that the week. The quality of the bonus week. Many cultures that bonus week burdens the healthcare team. So we'll come back to that. Did you understand what there's? Remember you said about your patient, you get an extra week with your family. They're asking what would the quality of that be. Scrappy, let us know who you are versus just your screen name. And we will address that in the next segment where we do some talking about these different topics and different questions that we have. So basically, you're bringing it back to the right IJ here and to probably the left subclavian here. So you have two parallel circuits to give you really high treated ECMO, effective ECMO flow. We'll call it that, because you have ECMO flow, but you have effective ECMO flow, and I think that really improves that tremendously. Here you see another parallel circuit, and in this particular case, it's veno to arterial. You see it there, and this one here is another veno to arterial. So this is VA, parallel VA ECMO support. The femoral venous is your access for one circuit, and your right IJ is access for your second circuit, going to give you very high flow. You look over here, and you have a little different configuration. This circuit here is basically veno-venous through an avalon, and then this circuit here is actually central cannulation going into the aorta. But again, they're parallel circuits. Here you have venous access going to right IJ, so it's a circuit, a VV circuit with dual cannulation, the old style from the femoral, from the low IVC into the right IJ, and central cannulation VA ECMO. And then, of course, here you can see the various different configurations that you would have for your, what we described earlier, VVA, VAV, VVA, all of this stuff. And just remember, the dash is where the oxygenator goes. Makes it very easy to understand what they're trying to do for that particular circumstance. So choosing the appropriate configuration and cannulation strategy for your ECMO is a process, and it's a dynamic process, and you have to understand what you are trying to accomplish in order to know which one of these circuits you need to use. And it's fluid, which I'll sort of discuss as we move forward. But when you go back and look at ELSO for the purely respiratory, which is the pie chart on the left, you can see that the overwhelming majority are pretty straightforward VV. There are some people that will do VA ECMO for respiratory failure, as is illustrated there, and it's a pretty good sized chunk, but it's certainly pretty small, but comparatively it's small, but it's still a pretty good sized chunk. I have never been an advocate, and I strongly advocate against using VA ECMO for pure pulmonary failure. You can get yourself into an awful lot of trouble doing that, and I don't like it. You can see that in the green slice, it's unknown. I don't know how you could possibly not know what your cannulation is. I guess they just didn't report it. and a very thin slice of VVA. Now, again, they describe it as VVA. That doesn't tell me a lot. Remember, we discussed this. Is that VV-A or is that V-VA? Totally different therapies. And without having that dash makes this chart not tell me a lot. But I can tell that something other than VV or VA is a very, very thin slice. In the arterial for cardiac failure, you can see straightforward VA is very dominant. You can have VV for cardiac failure if and only if, and we've discussed this many times, if and only if your cardiac dysfunction is secondary to hypoxemia. So if that is the case, you can put them on VV and their cardiac function will very frequently recover very quickly. And that helps you to avoid the going into the arterial circulation. The problem with that is that that shouldn't really be on that side. It shouldn't be in that data. It should be in the other data, because if it's heart failure secondary to hypoxemia treated with VV ECMO, really it's a respiratory problem. So it probably shouldn't be there. I think it's misleading in the sense that when would anyone put a patient with circulatory collapse on VV ECMO if the circulatory collapse was like for some other reason, like an MI or whatever the case may be? So I think that's odd. You get into the again, you have another very small slice that goes to VVA. Is that VVA
Right.
or is that VVA?
Right.
Which is it? Again, I think that's something that is a limitation. But my point, which I got off sidetracked, is that the blue and the red on the left and the right are the overwhelming dominant portions of how people do ECMO on a worldwide basis. This came from ELSO. If you look at, on the left is respiratory, on the right is cardiac, and you see since 1986, and really let's just focus on the past few years, 2014, 15, 16, you see that the number that survived in respiratory versus the number that died, blue on the bar is survived, yellow is died. You can see where we get the 60% survival or 40% mortality with VV ECMO for respiratory failure. And that's where this came from. This is all pre-COVID. COVID has very much changed this, which we will kind of get into. You look on the other side, and basically it's the inverse. It's reverse of what you just got through looking at on the respiratory. In the cardiac world, your chances of survival are about 40%, and your chances of dying or your mortality rate's about 60. Maybe it's a little higher, 35, 65, but it's right about that range if you look at those graphs and you go back and you look through all of that data. There are some advantages and potential pitfalls associated with different ECMO models when you're using arterial cannulation techniques. If you're doing it percutaneous, you can do femoral, but you can't do subclavian or carotid. Carotid, really, we're not even going to look at that because that's going to be more of a pediatric thing. No adult is going to get a carotid cannulation. Central cannulation, aortic, certainly would make sense if you're already in the operating room. Distal perfusion complications requiring fasciotomy, obviously going to be a lot more common in the femoral route, as you can see. You look through that. If you need amputation, again, you'd find the same phenomenon. Implantation requiring usage of a graft. In the femoral is less than 10%, but in the subclavian it's 79%. And I would argue I would never do put femoral or do subclavian return without a graft. I don't think it makes any sense to put a cannula in the subclavian. I think everyone should get a graft. In fact, the last one that we did just recently that I transferred to the other hospital, we did it on the left subclavian. And it was very nice, very elegant, very easy to do, and you really help to protect the limb when you do that way. But it says 79% on a worldwide basis. Do you need a sternotomy? Well, you only do if you're going to cannulate aortically, but no one's going to just do a sternotomy unless you're already done a sternotomy for some other reason.
Right.
You can see that the stroke rate varies tremendously. Femoral, 6% to 23%. In the aortic, it's about 21%. Again, we're not going to mention the carotid, but you can obviously see it's higher, and one would suspect something like that. Bleeding, of course, you're going to have a little, well, interestingly enough, it actually shows more in the femoral, and I'm assuming that's from cannulation site. You're also going to have a higher infection rate in the femoral for obvious reasons. And then explantation requiring vessel reconstruction, much more common in the femoral, which also makes sense because in the subclavian, if you're using a graft, you're really not going to have that problem. You tie it off and you tuck it in there and you're done. But these are some of the things. And of course, you have to talk about ambulation. Very difficult to ambulate somebody with a line coming out of their groin or two lines coming out of their groin. Complications arising during ECMO support, and this is, of course, from ELSO. Respiratory is on the left, cardiac is on the right. Hemorrhagic complications, about 12.5%. Surgical site for the cardiac, 17.5, and that's probably going to be because you're in the femoral artery that's just under higher pressure and they bleed more. You've got hemorrhagic surgical site bleeding, as you can see the difference there, higher in the cardiac. Neurologic brain death is going to be higher in the cardiac. Renal dialysis, requiring dialysis, fairly equal. Requiring hemofiltration, a little higher on the veno-venous, but I suspect that's because they last longer. Veno-arterial, you're usually getting done a lot sooner with those. They don't last quite as long. Cardiovascular use of inotropes, you see it higher on the cardiac, but it's actually quite high when you look at the respiratory veno-venous ECMO, because you do have that issue of the right heart starting to fail when you start developing pulmonary hypertension. It's really coming from that, I believe. Infections are going to be a little bit higher on the venous side as well. Limb ischemia, obviously higher going to be in the cardiac side because you're in the arterial circulation. All of these things, I think, make a lot of sense. But here's the thing. Choices have consequences. That's what the slide says in the background. And these are the things that I want to kind of discuss. Who, and equally important, when do we decide ECMO is appropriate? ECMO is not without its own consequences. Inadequate oxygen delivery, hypoxia, mechanical ventilation, high dose, and multiple pressors are prognosticators of bad outcomes. ECMO itself stimulates several negative reactions, which I'm going to get a little more into. Choosing to initiate ECMO is therefore not without significant risk of doing harm. So when we talk about early, let me get through the list and then we'll discuss it. Waiting to initiate ECMO, however, itself can do harm. Choosing the right cannulation strategy is not always as straightforward as it seems. Changing patient status must be recognized, and preferably early, and addressed early, which means if you need to add a cannula, you need to add a cannula. Setting goals should be discussed from the very beginning in a multidisciplinary approach before initiation, and when to or not to continue the support of any one particular patient. And that itself is not without its consequences, and we're going to really get into that in a deep way. So choosing to initiate ECMO is not without significant risk of doing harm. But waiting too long to initiate ECMO can make the disease process irreversible.
And we've seen that firsthand.
Where is the line? What's too early? What's too late? How do we know? There's a paucity of data on this. It is probably the most the most difficult conundrum to navigate for these patients, for us taking care of these patients, and the medical teams that are making the decisions to or not to do what we're going to do.
I agree.
Your thoughts on that?
I agree. No, I mean it's a hard decision to make, and as I say, with COVID, we're still learning, right? But there are many times when you want to initiate ECMO, and ECMO has its own disadvantages, like SIRS reactions, and of course, coagulation issues and bleeding and things like that. So it is a fine line, and every patient is different,
Yes, agreed.
And I think, we do our best, right? We do our best to try and find the sweet spot of, okay, that's it, it's time to put them on.
Yes.
You don't want to jump into it right away because maybe they have a chance of pulling themselves through.
But you also don't necessarily want to be like we did many times during the height of the pandemic, where they are actively resuscitating the patient because they were upstairs, unable to breathe, hypoxic for days and days and days, and finally just gave out, and now they're in a full-blown code, and they're trying to, they're rushing the patient down we're actually taking somebody out of the unit that may not really need to be out of the unit quite yet to get that patient in to put that patient on ECMO. And that happened several times.
Oh, I know. Yes. But waiting too long, by then the patient is completely wiped out, stressed out, and maybe there is no coming back from that brink of destruction that we've allowed to happen because we've been just sitting on this patient.
But remember what I said to you earlier. I was weaving you down. I was taking you down a path, and I was taking you there for a reason, because we're going to get back to it, okay? During my closing arguments.
I mean, early on in the whole COVID thing that we've had going on here, we had to wait sometimes because there was a lack of equipment, right? Lack of equipment, lack of staff, lack of beds. We didn't have a choice back then.
Agreed. And Vincent, good afternoon. Good afternoon, Vincent, if you're watching, Vincent Fan. And then Scrappy, who had asked, actually, I mean, it was a reasonably good, decent question, actually, because quality of life, the one that they redacted it, but it had to do with the quality of the extra week.
So if you give a patient an extra week, what is his quality of life? Well,
what's the quality of that week? Right. It was the question, but but they redacted it. They retracted it rather. It says message retracted. They took it back.
Okay.
I had asked who they were, but I guess they didn't want to tell us. But it's Scrappy. If Scrappy, you want to re-ask the question, we're happy, I think, to discuss it. But Vincent also says good afternoon, so we're saying good afternoon back to Vincent. Okay. So let's go back to the slides, but we'll circle back to that. Looking at extracorporeal life support and inflammation, something that you just brought up. Well, ECLS, which is extracorporeal life support, facilitate lung protective ventilation, which causes or results in a reduction in pro-inflammatory cytokines, decreased ventilatory induced lung injury, which we see very commonly, gives you myocardial rest if it's VA, and hemodynamic improvement, so you get all of those pressors and drips down, and improvements in organ perfusion, which of course all lead to decreased systemic inflammation. On the other hand, when you put people on ECMO, you have visceral ischemia and reperfusion injury, which results in the reactive oxygen species we're all very familiar with, which results in end organ dysfunction. You have bacterial component translocation. You get endotoxemia, which leads to a dysregulation of the inflammatory mediators, cellular dysfunction, activation of complement, coagulation, leukocytes, and platelets, which increases the systemic inflammatory process. So you are fighting a never-ending battle, much like we do every day. Every day that we are alive, that an organism lives, it lives in a state of homeostasis, but you have pro-inflammatory mediators and you have anti-inflammatory mediators. And as these are produced under various different circumstances, these are produced to counter it and keep us in homeostatic neutrality. When you become dysregulated, it becomes very difficult. You have surges of inflammatory mediators. You can have surges of anti-inflammatory mediators. You can then of course you start developing autoimmune problems. So it's a very such a simple, elegant physiology that either hypoxia or hypoperfusion can result in its stimulation, which by fixing that attenuates it. But the very thing you're going to use to attenuate this physiologic derangement is itself so aphysiologic that it itself can create all of these problems. So it is a very complex issue to deal with. I don't want to spend a whole lot of time on these slides, but basically just talks about various different modalities, whether it be cardiopulmonary bypass, VA, ECMO, VV, ECMO, or the extracorporeal CO2 removal system, ECCO2R. But obviously you see organ support is going to be cardiac and pulmonary. Again, VA, cardiac and pulmonary, VV, pulmonary, just oxygenation and ventilation. Duration, minutes to hours for bypass, days to weeks for VA, days to weeks, I contend months on the VV. Anticoagulation for CPB, standard cardiopulmonary bypass for coronary bypass surgery or for valve replacement, stuff in the operating room we're talking about here. Very high dose heparin is required. For VA, low dose heparin. For VV, low dose or no heparin. We've done a whole lot of that. There's reversal for protamine for the cardiopulmonary bypass patients, but we do not use protamine in VA or VV. Air-blood interface does exist in the CPB circuit, which creates its own set of problems, and that is absent in VA and VV, and also in the ECCO2. ECLS as a cause of systemic inflammation, and this is a very important concept, exposure of blood to the circuit itself. Inflammatory response mimics that of SIRS, which is systemic inflammatory response syndrome. A lot of this has to do with the interaction that the patient has with the circuit. And we talk about that a lot of times. When we initially put an ECMO on or when we're changing a circuit out, there is, generally speaking, a honeymoon phase in the very, very beginning, but then you start having these various things happen and you see this interaction take place. And so they have this very brief honeymoon phase, and then you'll see them start to dip quite a bit, become a little more hemodynamically weak, becoming a little more hypoxic. You'll see the inflammatory process. Their lung pressures go up. You start noticing they're holding more fluid. Urine output sometimes decreases. All of the things that we're looking at that tell us this patient is having an interaction with something, and then eventually that disappears. And that usually takes a couple of days. These reactions are humoral and cellular in nature. They are independent. Circuit biocompatibility may help to attenuate to some degree, but I think that though I am a very strong believer in that, I think that it is somewhat oversold as being truly biocompatible. I think the only way you're going to accomplish that is with complete pseudo-endothelialization of the entire circuit, and I don't think that's something that can be done too easily. Research on this is limited at this time, but there is a lot of research going on with this. You know, that's one of the benefits that existed when we used trasolol, a protein with its kallikrein inhibiting units. We saw tremendous decrease in thrombin generation, tremendous decrease in inflammatory reactions. So it was an excellent drug, I think, for those purposes. Contact system, coagulation, cascade, and of course the complement system. Following initiation, the contact system becomes activated, promotes coagulation, and drives inflammation. Onset is rapid and results in neutrophil activation, release of nitric oxide, and other pro-inflammatory cytokines, which, of course, CRRT is very beneficial. We're not talking about CRRT today, but that is a topic that I think is important that you need to understand as well when you do ECMO, because I think ECMO and CRRT are really something that I don't think you should do ECMO if you do not have CRRT, and I don't think you should do ECMO if you can't incorporate the CRRT into your ECMO machine. Different topic for a different day, but I thought I'd throw it out there. This is well understood through a lot of work that's been done on cardiopulmonary bypass. Everything we know about ECMO really comes from the cardiopulmonary bypass arena because we had done that for so long. Really, ECMO was LVADs. It wasn't truly ECMO. We didn't start doing ECMO until, really routinely pretty recently compared to how long we've been doing cardiopulmonary bypass. The contact system, however, triggers both the intrinsic and extrinsic coagulation pathways, leading to clot formation, which results in further inflammation. Even with anticoagulation, you have subclinical coagulation that does occur, especially in these ECMO patients who may be already hypercoagulable, or you're just using inadequate anticoagulation and depending strictly on flow. The problem with that is that you are always going to have areas of stasis somewhere, whether it be in the circuit itself, the oxygenator, or in the patient. And something that you need to be take into consideration. There is an expression of tissue factor from activated monocytes, or the TNF alpha and IL-6. Remember you talked about IL-6 just a minute ago? Induced release of soluble tissue factor without the need for tissue injury trigger. That's very important. So you are releasing soluble tissue factor even without a tissue injury. That's coming from an intrinsic pathway. These resulted in a 30-fold increase in thrombin formation, IL-6, of course, being a bad IL, because there are good ILs, interleukins. The complement system is also triggered with a rapid onset once you have established ECMO or ECLS, and usually lasts 1 to 2 days. This complement system activation is mediated by C5, C3, C3b, and terminal complement complex, resulting in leukocyte recruitment, vascular permeability, which is why we see our patients swelling up, and endothelial dysfunction, which, of course, the endothelium is so critically important to managing coagulation, right? Negative effects of ECLS also include platelet mediation of inflammation, endothelial dysfunction, neutrophil infiltration, which is very common when you see a lung injury, but ECLS-associated lung injury is from this neutrophil infiltration. And I don't know if you remember the drug Xigris. So ARDS was sort of coming on the scene. People were recognizing it, talking about ECMO as an alternative. And Xigris, I don't remember exactly the mechanism of action for that drug. It's off the market. It was pulled off the market. But the theory, or the reason you gave that drug, was to stop the infiltration of white cells into the alveolar capillary wall, which was what was thickening it in the ARDS, causing your gas exchange, or oxygenation and CO2 removal, to be compromised. And so anytime you have neutrophil infiltration into these membranes, which are very, very, very thin, you cause them to have an inflammatory reaction, which of course swells them. And when you are depending on diffusion, that's not a good thing to have happen. You don't want the distance between point A and point B to be very much, because it's not. And then, of course, you have to be concerned about bacterial translocation. And that is basic. We'll talk a little bit more about that, but that has a lot to do with gut ischemia, which is not very uncommon in ECMO patients. And we'll talk a little bit more about that, because it's really an important concept that I think a lot of people miss, and why I'm so insistent about always wanting to check lactates when something isn't looking right, because that's the first thing I start to think about, really, and it's because it's the biggest problem. If it's not there, great, the lactate comes back normal, but when it starts bumping, you got to get real aggressive, and if you wait too long until it's too high, I think you reach a point that you can't correct the situation. ECLS, however, can be a therapy for systemic inflammation. So I just got through talking about all the bad things that ECLS does. But if you are in cardiogenic shock, you're hypoxic, you're hypercapnic, it is a stress-induced inflammation. You will have a big-time inflammatory process. Ventilatory-induced lung injury. If you have a patient on mechanical ventilation with high pressures, you are going to cause a reduction in circulating cytokine levels when switched, an increase in circulating cytokine levels, which won't be reduced until you can switch the patient to a lung protection ventilatory setting. These very high pressures in the lungs are very pro-inflammatory to the lungs. And, of course, the reason for the reduction in cytokines when you go to lung protection ventilation is thought to be associated with reduction in the alveolar stress and strain associated with high pressures in your respiratory system. Ongoing research on ultra-protective mechanical ventilation is now also being explored. So we have our normal, we're looking to have the PEEP at 10. You want to have the pressures, your peak pressures and plateau pressures to be well under 30, 26 to 22 is ideal. You'll accept a very low lung volume to achieve those settings. But when you sit there with a lung volume of 120 cc's and a peak pressure of 40, your plateau pressure is 38 because your lungs are just so stiff and you just keep hammering them, they are going to continue to remain in a gross inflammatory state and never have the opportunity to heal. But we see it all the time. So before we get into ECMO and spontaneous breathing, let's stop there and let's discuss all of that. And I'm about halfway through, so I'm doing good on time. I'm paying attention to time, and I'm doing this, but let's take a break and discuss what I've said so far.
Okay.
Your thoughts?
No, I agree with you. There's good things about ECMO, and there's drawbacks to doing ECMO.
Mm-hmm.
And, I mean, I've seen that, too, where we go on ECMO, and maybe the first 12 hours, everything looks great, the gases look awesome, and then you get your x-ray back, and it is completely whited out.
It
And
just
you,
looks terrible.
You stay that way for 24 to 48 hours, and then slowly you start trending back up again.
Yes.
Hopefully.
It's very interesting to watch that, actually, because, and a lot of it gets so, it gets all mixed together. So you have the COVID patient with the ground glass opacities, of which I really, honestly, cannot really appreciate it as ground glass. I know what they're saying and looking at, but it doesn't look that way to me. It just looks bad. I just don't know how to describe it. The ground glass isn't how I would describe it. But that's what they see. And then, it gets worse, and the patient's PF ratio is terrible, and then we put them on ECMO, and they perk right up, and then the next morning we look at the x-ray, and it's whoosh, whited out.
Whited out, yep.
So all these consolidations. Well, that's not the COVID. That's the ECMO.
Which comes back to how long do we wait to put them on, and is this a good idea to put them on because you caused that?
Right, but that, and this is where I think it gets really complex. That's reversible.
True.
The question is, dead pneumocytes are not reversible. So with the COVID or any virus, if you cannot stop the replication and death of all of the lung tissue, and all you're doing is oxygenating the patient but not stopping that process, it doesn't matter how long you keep that patient on ECMO. You must, that part of the process, it has to stop, whether it be from the patient themselves or not. Now, if you keep them on high pressure mechanical ventilation, no, those lungs aren't going to heal. But if you don't put them on ECMO, they're going to be continuously hypoxemic, which is going to cause pulmonary hypertension, which is going to cause right heart failure, which is going to cause higher inflammatory processes, which is going to burn their lungs out as well. It's a very difficult, frustrating set of circumstances. But, okay, so I think we've belabored that. Does anybody need a break? Can we you want to take a 5-minute break and some tea?
Totally up to you.
You want some tequila? I don't have any, but we could run to the store real quick. It's not far. No?
I'm good.
Okay.
I'm good.
So maybe an iced tea or something like that?
Whatever.
Let's do that. Let's take 5. Can we do that? Can we take 5 minutes, and I'm going to come back and talk about ECMO and spontaneous breathing. And I'm still weaving my way down because I'm still going to come right back to what we discussed just a minute ago. Okay, it's 5 minutes. ready for you. Wait on you. Welcome back. Okay, let's go on to part 5 or whatever it is of this thing. So let's go straight to the slides. We have ECMO and spontaneous breathing. So we have, during this COVID, interestingly enough, I didn't realize that this is not something brand new. People have been doing this. But most awake ECMOs were patients who were
Bridge transplant.
yes, and somewhat compensated, and they just needed a little extra oomph to kind of get them through till their transplant was available. They weren't acutely ill. Completely different phenomena. But there's some very interesting aspects of mechanical ventilation and with spontaneous breathing that make what we do very different. So spontaneous breathing fundamentally removes the negative effects of mechanical breathing, which you have just talked about, or mechanical ventilation. Potentially, however, adds the stress of labored breathing, especially those patients with what we have seen many times, this rapid guppy type breathing. It's painful sometimes to watch them do this, and I contend it's not. I contend that it's not good, but let's sort of just look physiologically at mechanical ventilation, which is on top, versus spontaneous breathing. So what you're looking at is a patient in supine position. The blue lines that you see, which are equal on both, is basically weight from gravity and abdominal pressure, going from lower to higher as you continue to move back to the back of the patient posteriorly. And then if you look up at the mechanical ventilation, the dotted line is the deflection of the diaphragm during end inspiration. So what you notice is, here's your diaphragm at end expiration, and here is your diaphragm during end inspiration. And you'll notice that it deflects almost entirely. It's very angular, and it's up anteriorly. And of course, you have less weight here because of gravity forces. So this part of the diaphragm does not drop down. And of course, this posterior portion of the lung is a highly dependent area of the lung. So you lose any of your oxygenation and CO2 removal, or your gas exchange, however you want to couch this. And of course, you end up with a big VQ mismatch in this area. Here you see the little graph, white being normal, in the green, and then yellow and red. And then if you prone the patient, you have a different phenomenon because you're taking this weight and you're reversing it, right? Mm-hmm. So then you will deflect more on this side posteriorly than you will anteriorly. Here you see in spontaneous breathing, the solid line, of course, is end expiration. At inspiration, the chest goes out, plus the diaphragm, because it's actively contracting, contracts along its entire axis and deflects down in a dome-shaped or curved arch-type shape, and you get much better perfusion and ventilation of the entire lung. Mm-hmm. Still going to have a little less in the dependent region, but it's not just a big giant VQ mismatch. Okay, so very important to recognize and understand that mechanical ventilation is not just applying pressure and inflating in the lungs in that way. It has significant impact on how the lungs are ventilated, how the diaphragm moves, which is the cause of it, and how the oxygenation, where you have, again, because of gravity, a higher degree of blood flow going here posteriorly, but yet that's the part of the lung that's not being ventilated, therefore not able to exchange oxygen either. Mm-hmm. So very important concept to understand. So there are pros and cons of spontaneous breathing. Patients preferentially move the dorsal, more compliant part of their diaphragm with spontaneous breathing. Ventilation is therefore directed towards the most dependent and better perfused part of the lung, leading to optimal ventilation perfusion matching. We just discussed that very thing. The tone of the respiratory muscles in the awake spontaneously breathing subject guarantees the expansion of chest wall and lungs at end expiration, which is your functional residual capacity for those that are respiratory therapists or pulmonary care people. Maintaining diaphragmatic contraction and avoiding controlled mechanical ventilation could prevent ventilator-induced diaphragm dysfunction, which is, you start to lose you're paralyzed, you're sedated and paralyzed for a couple of months, and your diaphragm's not going to work too terribly well. None of your muscles are. During spontaneous breathing, air moves from the mouth, of course, to the alveoli through a decrease in intrathoracic pressure. We breathe because of a negative pressure intrathoracically, which sucks air from the atmosphere into our lungs. It's a negative pressure effect, which favors venous return from extrathoracic organs, maintaining cardiac filling and output. The same mechanism seems implicated in favoring pulmonary lymphatic drainage. So you'll notice that when you look at, you want to know if your patient is hypovolemic or not. You look for your and you are mechanically ventilated. You look for your systolic pressure variation. You'll notice you have a respiration, your pressure will go up. Expiration, your pressure will go down because you're occluding and unoccluding your venous return going back to the heart. The avoidance of endotracheal intubation could reduce the incidence of ventilatory intubation-associated pneumonia through the maintenance of the natural barrier defenses against bacteria in our mouths and our throats. And then, of course, the cons to spontaneous breathing. Transpulmonary pressure is one of the forces implicated in the development of ventilatory-induced lung injury. Spontaneous breathing generates positive transpulmonary pressure, which is airway pressure minus pleural pressure. Similarly to mechanical ventilation, lung damage might therefore also derive from spontaneous hyperventilation or spontaneous ventilatory-induced lung injury. We have seen patients who were not intubated who developed tension pneumothoraces because of this very thing they're describing here. When the work of breathing is very high, the strenuous respiratory muscle effort can lead to high oxygen consumption. So we've seen that many times. Yeah. You have a patient, we're on ECMO, they look great, but they start just trying to breathe on their own, and they're working so hard and they're consuming so much oxygen, it makes it, their cardiac output goes way up, and now we have a big effective ECMO flow reduction or a native cardiac output ECMO flow mismatch. It's similar to a VQ mismatch, only it only has to do with blood and effective ECMO flow, and that then becomes a problem. It also leads to an increase in CO2 production and a very high cost of breathing, which in turn could worsen the hypoxemia that we're trying to treat. If gas exchange needs are not met in other ways, for example, through extracorporeal respiratory support, sedation, intubation, and mechanical ventilation, could be necessary to avoid muscle exhaustion. And I contend a very high stress environment, which leads to more stress hormones being released, which results in, a vicious cycle. So in conclusion, although mechanical ventilation is commonly employed to avert catastrophic hypoxemia and hypercapnia in patients with severe ARDS, mechanical ventilation per se can cause lung injury and accelerate the disease progression. Extracorporeal or ECMO provides an alternative to rescue patients with severe respiratory failure that mechanical ventilation fails to maintain adequate gas exchange. The timing of ECMO initiation based on the risks and benefits of ECMO has been widely investigated. In the running of ECMO, the protective ventilatory strategy can be employed without worrying about catastrophic hypoxia and carbon dioxide retention. There is a large body of evidence showing that protective ventilation with low tidal volume, high PEEP, and prone positioning can provide benefits on mortality outcomes. More recently, there is an increasing popularity on the use of awake and spontaneous breathing for patients undergoing ECMO. Lastly, we discussed ECMO weaning. The majority of centers prioritized weaning VV ECMO over mechanical ventilation, while others preferred to wean mechanical ventilation first. So that is a controversy on which direction should we be going. My real question is, of course, if you're not intubated, then you can't wean the ECMO, the vent first. So it's obviously going to be the ECMO. I really am I'm sort of iffy about this awake ECMO, whether or not it really makes sense, or we should be trying to get patients weaned off of the ECMO as soon as we can, because I do see the ECMO as having its own morbidities associated with it. And now, I wouldn't say that for everyone, but I think there are times we should be intubating patients, and there are times when I can see where, okay, we don't need to just yet, but we shouldn't be so absolutely determined never to, because if they need it, they need it, right?
Mm-hmm.
They're not going to recover if they can't rest.
Exactly.
There has to be a balance.
Yes, exactly.
So now, for how long? How long do we do this for? That's a very serious question. This study that came out of Qatar, but I think it's very good, Dr. Raza, and published it in 2017, is about a patient who went 300 plus days on ECMO. Lessons learned. And I really want to go over each section of this, because I think this was very, very well done. VV ECMO provides, of course, respiratory support for ARDS until the underlying acute lung pathology improves. VV ECMO support for greater than 100 days is rare, and in most situations requires a destination therapy, for example, of lung transplantation. This may not be an option in some centers. In this particular hospital, they describe a case that was their longest, greater than 300 days, with severe residual fibrotic lung disease and the inability to wean off ECMO. This presentation briefly discusses the multifaceted challenges and lessons learned from this experience. They go on to, in their discussion and lessons to be learned, prolonged ECMO can lead to various challenges, some of which are briefly discussed below. General. There are general ECMO-related issues. These are more common due to prolonged ECMO run and include membrane failure, thrombosis, DIC, etc. Right ventricular failure may prove to be a terminal event in these patients. Rare issues are prolonged heparin therapy may lead to osteoporosis and heparin-induced thrombocytopenia. Their patient was positive for HIT and was managed with prolonged argatroban therapy. 3. Unusual complications. Extensive fibrocavitary lung disease can lead to large lung cavities impairing gas exchange. Percutaneous pleural pulmonary procedures are at high risk during ECMO. We performed percutaneous drainage of large bullous lesions without any untoward event. Unexpected hypoglycemia and type 2 lactic acidosis were also unusual events in this patient. Potential etiologies and management of these rare events will be discussed, of course, later on in the presentation. I probably am not going to get into those things. Here's where I start to get excited about this and what I wanted to bring up. Team morale and psychological support. Prolonged ECMO patient care with no destination therapy can be extremely stressful for caregivers. Frequent debriefing sessions may help to mitigate these issues. Formal, personal, psychological support should be readily available to all team members to mitigate stress-related complications. I'm going to tell you, I'll tell everybody out there, I have PTSD from this COVID experience.
Yes, I agree.
From our practice, what we went through, I dreamt about it last night. I dreamt about it last night, and it was a bizarre dream. The patient decannulated themselves.
Oh, Lordy.
But it didn't start off that way.
Okay.
It was a long dream, and it was dreadfully painful. And it took forever,
This-
it seemed.
Yeah,
But
this
it
has
ended
been
with the
very
patient
stressful.
decannulating himself and dying.
This is very stressful. I can't tell you how many times I've ended my shift at work for an ECMO patient, maybe lost that patient, gone out to my car, and just, before even going anywhere, just cried.
Mm-hmm.
Just cried my eyes out.
Mm-hmm.
I mean, we're all going to have PTSD after COVID.
I think we all do.
Yeah.
But we're expected
Or we're going to be alcoholics, one or the other.
Yeah. Oh, yeah. Both. Or both. But we're expected to be stoic. Yeah. We're expected to be stoic.
We are.
We're
And you are.
expected
While you're
to-
there, you are. But we're only human. And you leave, and it just,
That's
man, it
not
hits
how
you.
we're seen.
Yeah.
That is
But
not
we're
how we're
human.
seen.
And
Sharon.
this new generation of awake ECMO that, you know, some of us didn't have any experience with in the past is really opening our eyes and allowing us to become close to these patients and
Mhm.
close to their families and getting
Mhm.
to know them. So when things don't go well and it's, you know, we lose them, it hurts
Mm-hmm.
mentally and physically.
Mm-hmm. Absolutely. Other issues with this very long ECMO run, skin integrity and musculoskeletal function. I can tell you that we have seen that in our patients that didn't go 300 days. Although we'll talk
Yeah.
about Michelle, she went 3 months.
Are we allowed
It was pretty close to 100 days. Besides the adequate nutrition, mobility and muscle exercises are extremely important to maintain musculoskeletal functional status. We all understand that. We were actively mobilizing this patient while on ECMO to prevent these complications.
Mm-hmm.
So, and you can't do that if you're on the ventilator.
Mm-mm.
So that is another problem. However, psychological issues for the patient, prolonged ECMO, ICU stay, limited mobility, limited family connections are a rich recipe for depression and other psychological issues. We saw that several times with several of our patients. Team members from patients' countries, birthday, of course this is in Qatar, so they're going to have a lot of people that are going to come from somewhere else, but having those connections are going to be very important for patients to stay connected and they themselves not becoming depressed. We had
This
a patient.
is an area too. I'm sorry. I didn't
No,
mean to interrupt.
please.
But this is an area too, especially in our awake patients, that we need to build on in the hospital. Not us per se, but the hospital needs to have advocates for these patients. You know, some psychotherapy for them to help them move through this, because these patients are awake. They can talk to you, and they need someone to say, you know, just to walk them. I'm not a psychologist. I don't know what to say to these people. All I can do is say, you know, try your best. You've got to get better. You've got to do this for your kids, your wife, or whoever, you know.
Absolutely.
But someone
Well,
needs to
that
go
and
in
just
and
listen
talk
to
to
them.
Yes.
Let
yes.
them talk.
Exactly. Exactly.
You
Because
know,
we've
we
seen.
go in there and rah-rah them all the time.
Yeah.
We go in there, I go in there and do the Sergeant Joe. Okay, you go in, you're a little more sensitive.
Mhm.
You do it in a different way. I have my way of doing it. I march them.
But how many of our patients have initially been like, I can't do this, I'm done, I want out. And then all of a sudden you maybe say the right thing, the one word, your kids, your wife, you got to go home, you got to do this. And they turn it around.
Yeah.
But we can't do this job alone, you know, of handling psychological issues of ECMO and ECMO, extended periods of ECMO.
Correct.
We need help with that. And I think that's an area that hospitals are really falling behind on.
I would agree with that 100%. Ethical and other considerations. ECMO to nowhere. Create tension among the team members due to different views about the ongoing care of some of these patients. Consideration of withdrawal of care is a major ethical issue and needs to be resolved by involvement of all team members, local ethics committees, religious scholar input, consideration of local policies and input from the patient and any available family members. That's a very strong statement. ECMO to nowhere to somewhere. Explorations for non-regional transplant centers. Sometimes it's just not going to happen. Charitable organizations conducting fundraising activities for those people that can't afford it. But in conclusion, prolonged ECMO therapy poses its unique challenges. Good team dynamics, frequent debriefing sessions, and ethic consultations are extremely important during care of these patients. Innovative solutions in collaboration with regional and distant transplant centers may provide an opportunity for destination therapy in these patients. Now, sometimes that's just, we're right here in Houston. They're just down the street. patient's not a lung transplant candidate. We can't just get them transferred to a lung transplant center because they're not a lung transplant candidate. Not to mention there are only so many lungs and there's just aren't enough. So, really this is going to be a bridge to recovery or a bridge to nowhere. And we just recently had that with a patient who was asking for a gun so that they could end their own life. That patient ultimately went on to die. Not that way, but they did die, and that's
But
a
we've
horrible
had
event.
a patient that also said that and went on to go home.
This is true,
So
and we're going to talk
two
about
sides
that.
to the coin.
I completely agree. In this, what you're looking at here is from a patient that was done in China. This is coming from the Frontiers in Medicine, Intensive Care Medicine, and Anesthesiology. But a 61-year-old man who went in with COVID around day 6. They post-intubation. They had a very low PF ratio. It dropped all the way from 200 to 123, and their PCO2 jumped up to 64. Chest X-ray showed diffuse opacifications with the lung fields, and they went ahead and made a decision to put the patient on ECMO, but they intubated first. Now, this patient went on to survive. This patient actually survived. But I wanted you to take note of something. 1, 2, 3, 4, 5, 6 oxygenator changeouts because of hypercoagulable coagulopathy.
Right.
Very interesting. So in 111 days, this patient survived, which I find very interesting. There was a very good article, and this is actually an article that was written by an Elaine Volsteck from the UK, and he was actually discussing an article that was published in The Lancet by Ryan Barbaro and colleagues. And they reported an analysis which was an international cohort of adult ECMOs for COVID-19 who were supported, again, with ECMO. Patients were divided into these various 3 groups. I don't really want to get into all of the details of the study, but here's the thing. The findings suggest that mortality rates for ECMO-supported patients have increased by 15% between an arbitrarily set early and late stage of the pandemic, on or before May 1st versus after May 1st. And therein lies the difference between the original variant, the original strain, the beta variant, maybe the gamma variant, but the delta variant at May 1st. That, I believe, is the differentiator. If you were treated, and I'm going to show you some reasons I say that, if you got the original strain or one of the earlier variants versus the delta variant, your chances of survival were much higher, more than a 15% differential in our experience. Absolutely.
I feel like it's the other way around.
Oh, God, no. Our numbers don't support that.
Okay.
The data doesn't support that. Going on with this continued discussion from Dr. Volsteck, earlier reports on ECMO for COVID have shown very high mortality just on their own. Later cohort trials showed similar outcomes compared to other types of ECMO for ARDS, encouraging an increased use for ECMO in ARDS, or COVID ARDS. So basically what happened is, in the very beginning, we had very high mortality with COVID, with putting patients on ECMO for COVID. But then over time, it kind of got seen that, well, no, the results are very similar. If you have a 60% survival, that's not bad if you're, in really bad shape, right? But that didn't really vet out, I don't believe. But in the end of the day, that's why we saw so much ECMO use, was that the results seemed very encouraging when you looked at it on a global scale, not necessarily just your local area, or maybe even regional, or maybe even national. And these are numbers that are coming from a global perspective, which can be good, can be bad. I think it just depends. In the study with Barbaro and colleagues, mortality rates for ECMO-supported patients increased 15% on or before May 1st of 2020. The analysis also showed the highest mortality was at those centers that had only begun providing ECMO on or after May 1st. Wow. I think that's for 2 different reasons. A more virulent strain in Delta and the inexperience of what really happens when you put somebody on ECMO and how much it really takes to do it. Further, the report states, this analysis shows that the majority of patients supported with ECMO will now die. And that is not just die on ECMO. That is basically 3 to 6 months, even if you get them weaned. They're having events and they're not surviving. This phenomenon has been seen in many other clinical scenarios and is thought to be a key explanation for the superiority of being allocated to an ECMO center. In this particular case, what they're saying is ECMO centers have better ECMO outcomes because they will not put everyone referred to them for ECMO on ECMO. A lot of times they're saying no when a community-based hospital would say yes. And they're essentially limiting their care.
Do you believe it's the fact that ECMO centers they're better equipped for this?
Not necessarily. I don't think that's the only reason. I think if you go and read this article, you'll see that a lot of times they're not putting patients on ECMO that someone else believed needed to be on ECMO and would have put on ECMO had they had the opportunity to do it. And what that tells me is there is, and we discussed it ad nauseum, I think, today, if you take a patient who doesn't need to be on ECMO, can get by without it and put them on ECMO, you may in fact do the harm that it takes to have them succumb to their disease.
Right.
So that, I think, is the differentiator. I think an ECMO center is not necessarily, like we're not an ECMO center, but we do ECMO damn well.
Oh, yeah.
But we're not an ECMO center, technically, right? But we do a lot of it, all right? However, I guess we're a quasi-pseudo-ECMO center, junior ECMO center. You can call us whatever you want to call us.
Somewhere up there in ECMO center
Right,
league.
but I think what an ECMO center offers is that wisdom of, I don't want to put this in too early, I'm going to wait a little bit, and getting people through without ever having to go on ECMO and the consequences that are associated therein. Mm-hmm. That's what I think. That's my view. So I want to talk about Ricky Ham. He's a pilot, a medevac pilot from UAB. He was for 17 years. He got COVID. He was UAB's longest ECMO survivor at 147 days on ECMO. He went home. He is still on supplemental oxygen. He will have to use an extra strength CPAP machine at night to help with his breathing. He has suffered and continues to suffer profound hearing loss. He goes to a speech pathologist. And a quote from him during this interview was, "We built it to live in the rest of our lives." This is his house he's referring to. "We built ramps and wide doorways and no stairs. But it was for when we grew old. I never expected to need a handicapped access quite this soon." Mm-hmm. And this is probably the best he's going to get. He's alive. Can't argue that.
He's alive.
Chris Hernandez, original strain. He went home. He went back to work. Chris went back to work.
That's incredible.
Okay? Mm-hmm. He was the first. He shut the Houston rodeo down. I can say his name. It's not a HIPAA violation. You can find him online. He's done interviews at public. Look up Chris Hernandez and Houston Rodeo. Michelle Tate, she does plenty of interviews now. She did great. She was an original strain, though, or early variant. She went back to work. Yeah. She was a Zuma instructor ahead.
She's a special lady.
I only put the initials. I didn't put the name because he hasn't done anything like that, or she hasn't done anything like that, or whichever the case may be. But he's improving, and he's getting better. Here's where it gets really confusing for me and difficult, and we're going to come right back to what I had discussed earlier. From the National Museum of Civil War Medicine, you do the greatest good for the greatest number. That is what triage is in the Civil War, or was, and is, in fact, still today. Mm-hmm. Now, let me give you my scenario. You have 5 ECMO machines. You have 10 ECMO machines. Have as many as you want. I don't care.
Okay.
Okay? There's not an unlimited supply. There's a limit.
Okay.
Okay? Let's just say you have 5.
Okay.
Rush of patients with COVID. This patient's 26. This patient's 31. We got to give them a chance. So there goes 2 of your machines.
Mhm.
You got 3 left.
Mhm.
You have another one. He's 46 years old. Put him on. Another one. It's a female that's peripartum. We have to put her on, right? We got to save the baby and her. Put her on. Now you got 1 machine left. Somebody else comes to the door, and in your philosophy, everyone gets a chance. You put the next one on. Now you have 5. You have no other machines. All of them are going to be on for 100+ days. What do you do with the next 5 that come through the door?
I don't know. I mean, if there's no other equipment, then my hands are tied. If I have a heart-lung machine or something else.
You have
but
nothing
the
else.
thing
These
is,
are your only options.
but-
You have 5. I'll give you 10. You have 10 patients
I can't
now.
play God like that. I mean, if someone
But
comes
you
through
are
my
playing
door,
God
no,
like
but
that.
if someone comes through
No,
my
you
door.
are playing God like that. You are. The problem is you just don't like this problem.
No, I don't like this problem.
Right. But these are the problems.
Well, then you look
problem
to other
is
avenues. I mean,
Right. There is
we've
no
done it.
doubt
We've borrowed equipment from other hospitals, shuffled things around.
nobody has any.
Oh, well then.
Let's just be realistic.
You're really
Let's
making
just,
this
I mean,
difficult.
yes, we did that. We did that. We borrowed pumps from anywhere we could get them.
Exactly.
Seriously considered, never did it, so I don't need
So what are you
anybody
gonna- are you
coming and
gonna
getting
have-
after me.
Are you going to have
We seriously considered
5
using one from a
machines
pig lab.
and put 4 people on, and you have 1 extra machine for whoever comes through the door? But that 5th guy that should have probably gone on there initially, you're just going to say, no, I'm sorry. We have a machine, but we're not going to put you on right now? Are you really going to do that? Or are you just going to put him on and, we'll see what happens with the next lot that comes through the door?
I mean, these are, well, you won't see them because they won't get referred to you because they can't. I mean, we've actually been in that situation before.
I mean,
We've had to
maybe-
make that choice. Here's the problem with everyone gets it for however long it takes.
I mean, and when COVID first started, we were putting patients on, they were probably a little bit older than we would have put on normally, right?
Yep.
And we put them on to give them a chance.
Yep.
And some of them did okay, and some didn't. But
Right.
you have to give someone
But
that
when all your
chance.
resources are consumed,
Okay.
the ideal patient, what do? It's a reality of the circumstances. Here's the issue. You have a patient. They've been on for 30 days, not showing any improvement. Those patients, and we've had anomalies that went almost 3 months, 90 days. Michelle went, I think, 93 days, if I remember. I don't remember exactly what it was. It was 89 days.
I thought it was
However long it
78
was.
maybe.
It was a long,
78.
okay, it was a long time.
Mm.
Nearly 3 months, whatever that ended up being. It was a long time. There were several times when I didn't think she was going to, if somebody else comes in the door that needs this, we really need to be thinking
Well, that's
about
what I'm saying.
stopping.
That's what I'm saying is,
But
look,
how,
she turned around and she
She
went home
did.
and she's working. And
but yes, and that's great for her. And I want that to be for her. And for every patient that made it like that, I want them all to do well. I do. But what's the cost? In other words, although you don't know them, although they weren't your patient yet because they didn't have the opportunity for ECMO, how many people that may have been as good or better of a candidate didn't get it? So how many did we, and it could be 0, I don't know. Okay, this is an unknown, and I recognize that, so I'm not disputing it. But the question is, how many people died
because we didn't
to
have enough.
save the one?
Yes, I understand.
And is that how triage works? Do we save the one at the cost of many, or do we save the many at the cost of one?
But it is
It's
a
an
war.
ethical
This
dilemma.
This is not a war where there's more people coming
That
to the
was a
door.
war.
Yeah, well,
This
I
was
was
a
just
war.
about to say, yeah.
Yeah.
But we didn't know how many more patients were going to come through our doors. So that's what I'm saying. You can't sit on a piece of equipment and say, well, I'm keeping this for somebody potentially coming in the door, when you've got a guy over here that needs it now. You going to tell him no because you're waiting on a potential to come through the door? You
We
can't
had
do
two
that.
patients that, thank God, that we didn't have an equipment malfunction. Because had we had an equipment malfunction,
Heart-lung machine.
there was, we were in a lot of trouble. Okay, I don't know how we got through it all.
I mean, when COVID started, look, they were popping ventilators out of everywhere, right?
Yep.
Maybe we needed to do the same thing with, I mean, who's to say we're out of the woods yet and we're not going to have another surge, but maybe that was something we should have thought about, was having some sort of equipment on the standby for all these patients. Maybe it wouldn't
If
have been
we'd
a
had any
full-fledged.
equipment on standby, we
had-
would have used it.
Yeah, we probably would have, yes.
We would have used it. And should we have? Because everybody was fighting over getting equipment. In fact, an unintended consequence of all of this is a bunch of companies have created a bunch of, I'll just say it, crap equipment, and it's in the market, and hospitals are buying it, and these companies are making money, and it's crap. And it's fundamentally wrong, but it's reality. And that's something we're going to have to deal with moving forward, is lousy equipment, because it's flooded the market.
Yeah, but it's equipment that could tide you over until you can free up your own equipment, right?
No, they're selling it. I mean, it's like the Abiomed one, that they have. You can't the oxygenator goes in a cover. You can't even see the oxygenator. It's just the weirdest little thing. Does it work? Sure, it works. But it's like the Life Spark, same kind of thing that Levanova bought from Tandem Life. Yes, it works. It works. That's all I can say about it, is it works.
Well, I mean, then it's something. It's a backup for someone.
Yeah.
I mean, if someone I loved came through the door and you said, well, we don't have our normal equipment, but we've got a new piece of equipment here we can try, I'm going to be like, go for it. I mean, that's our job. That's what we're here for.
I did that, and I had a lot of complaints from people saying, we don't want to use this boat anchor, okay, including you.
Yes, you're right.
All right?
Don't
People
bring up
weren't
any
too
names.
happy with me because I didn't just get one of them. I got two of them.
But we used it.
And we had two patients
But
on with them.
We used it.
We did.
We weren't happy, but we
But
used
I got
it.
a lot of complaining.
I know. Well, come on. We're stressed out.
Okay.
PTSD.
This is true. Okay. So should Sharon, let's see, daily transparency of the ECMO trajectory is absolutely necessary. Yes. Jay Howard, I could not agree with you more. I think that is an excellent point. I think we need to be, it's one of the things that we've been working on, is developing that kind of system, if you will, where there is an actual ECMO coordination team that works together so that information to the clinicians is disseminated, whether it be perfusion, nursing, specialists, physician, respiratory, whatever it may be, like when they do rounds, but on a different level than that, only specifically about these ECMO patients. And I think we need to have better coordination and agreement with who we have on, how long we have them on, and whether we should put them on at all, whether we should intubate them at all. I think we really have to have a better, because it's so dependent on who is the pulmonologist or intensive care person on that particular day as to which direction they're going to go with this. And I think you need better, I think you need to have a team approach, a multidisciplinary approach with input from everyone making a good decision. And I don't think we should be so disinclined to go ahead and ventilate somebody with ultra lung protective strategies if not being intubated causes them to do so in such a laborious and stressful way. I think that's that I think you lose the benefit of spontaneous breathing or non-mechanical ventilation when they're doing it like that. But very good point, Jay Howard. All right. I've got nothing else. Why don't you close us out?
No, you close us
No,
out.
you close us out. Come on.
I don't know what to say.
Say hi to Tammy.
Hi,
Hey, Tammy. Got a replacement for you.
No.
Found one that quick. Tammy's doing a case, by the way. We miss you.
We do.
I wish you were here, too. I wish you were here, too. All right. Well, very good. We're going to go ahead and close it out. I want to thank you so much. I think you have some very good thoughts, very good insight, great experience with this, have a lot of passion for it, and I respect that and appreciate it very, very much. This is I wish it was an easy topic, but it's not.
No,
It's intellectually very challenging and emotionally even more challenging.
Mm-hmm.
So let's see. We have coming up webinar schedules. PerfWeb 72. PerfWeb 73 is Wednesday, December 1st, with the Vanderbilt Faculty Forum. They're going to be doing their 2020 review of their heart transplants at Vandy, VUMC, followed by the Journal Club, Tammy's Paracenter Journal Club, Neurologic Recovery after 10 minutes of absent cerebral flow at normothermia. That should be a very interesting. Yes. I'm looking forward to that. That's going to be a good Journal Club case or presentation. And then John Ingram on his Knowledge Nuggets is going to be talking about albumin. Do we give too much or not enough? Well, I can answer that question for you right now. You cannot give too much albumin. It's impossible. It's absolutely much better for volume, especially volume expansion, reducing edema, you name it. Now, you got to be careful. You don't give it when you're in heart failure and the patient's third spaced and they're not making any urine, and you throw in a bunch of albumin, you tip them over the edge real fast. But if you're on ECMO or you're on CRRT or you're able to do it in a sensible way, it's the only way you can really clear their edema. You have to have a way of removing the plasma, the excess plasma water. And then December 16th, we're going to be doing PerfWeb. We're going to be redoing PerfWeb 68 because we never did it. We had to cancel it, so it's going to be a rescheduled, followed immediately by PerfWeb 74. So it's going to be the factors that influence DO2 during CPB. Why do you need a perfusionist? And then to follow that same day is going to be the economy of perfusion, because I think a lot of people don't understand how perfusion makes money for a hospital, and I think it should be very interesting. It's going to be very interesting to hear a lot of those things, because I had to learn a lot to do these. They say that the person who learns the most out of all these lectures is the person who does the lecture, because you have to do all of this reading and making the slides and blah 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 blah, and then at least look over it several times so you at least mostly sound like you know what you're saying. So we're going to be doing that, and then we're working on the 2022. We have a new studio it's going to be here, but we are doing. We have a new. What did you call it? What do you call the new thing we're doing? The new thing. Just a new streaming device. New technology. So advancing the technology so that we can have a lot more in the way of graphics, add a lot more things in. We're going to be working very hard over the holidays at developing those relationships with other people. Hopefully COVID continues to be on the decline and it doesn't uber surge, that we'll probably see some bumps in the road, but they're not crazy, and we can continue to develop that. We're developing our nurse program. We actually offered sent an employment agreement or offer letter to a nurse who's coming out of the medical center to help us develop our nursing platform, which is going to be, I think, fantastic. Trying to develop also a symbiotic relationship with a couple of the institutions, local systems that exist here in the Houston area, to be our surrogates. And we're going to continue to develop those relationships with various different people to bring increasingly more advanced content and diversifying it for perfusion, for nursing, and for physicians. But we're really working at retooling the studio, not in the sense of making it look different, but increasing our technological capabilities to be able to do things we right now just can't do, because it'll just fry the processor. It just shuts the machine off if you start getting too complex with it. Anything else, Magic?
Yes, I saw some people purchase this webinar, so tell them if the quiz is up.
Oh, if you purchase this webinar and you need your certificate, the quiz is up. It's already been done, so you can go on there, complete your quiz, get your certificate, and be on your way. And thank you for doing that, by the way. For those that watched it for free, of course, we're happy. We're glad you did. We love people to participate in these programs. We always enjoy the audience, and we are here to give information. But if you did buy it because you needed the CEUs, we thank you for that very much. It helps keep the lights on just a little bit longer, so we appreciate that. But buy that app. I need to sell 1 million of them. I think we got about maybe 1,000, so I have a little ways to go, about 990,000, 99,000 to go. So come on, help me out here, all right? And but that's when I retire. 1 million,
Okay.
1 million of my apps. I thought it would have been viral by now. I was hoping it would be. Like, it would just sell like hotcakes. That's really what I was hoping for. I guess I should have done Angry Birds perfusion style.
There you go.
Instead of having like little hammers or anything like that, they throw tubing clamps. Yeah, that'd be perfect, right?
That would be.
All right, thank you very much. We'll see you on December 1st. We'll see you then. Thanks, everybody. Thanks, David. Thanks, Magic. Thank you again, Sharon.
Thank you.
Be safe, everyone. Bye-bye.
Bye.